Hi, everyone, and welcome. We apologize. We had some technical difficulties, but I think everyone is online now and able to hear everyone else. Welcome to today's virtual Thalassemia Grand Rounds. This Grand Rounds is a partnership between the Cooley's Anemia Foundation and the Division of Blood Disorders and Public Health Genomics at the U.S. Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Jennifer Yu, and I'm a pediatric hematologist oncologist at Rady Children's Hospital in San Diego, and the medical director for our comprehensive thalassemia program at the University of California, San Diego. I'm especially proud to introduce today's presenter, Dr. Ash Lal. Dr. Lal directs the comprehensive thalassemia program and iron disorders program at the UCSF Benioff Children's Hospital in Oakland. He is also professor of pediatrics at UCSF School of Medicine, Division of Hematology, and the leader of our Thalassemia Western Consortium. Dr. Lal is a great advisor and is always willing to listen and provide advice on tough cases. He has been a great supporter of many of us, including my interests in thalassemia and smoothing the course of patient transitions to adult medicine. I am lucky to call him a friend and colleague. We are both delighted to be with you today for the virtual Thalassemia Grand Rounds, and we're grateful to the CDC's Division of Blood Disorders and Public Health Genomics and the Cooley's Anemia Foundation for this invitation. Today, we will take a deeper look at recommended treatments for hemoglobin H disease, a form of alpha thalassemia. And here are the learning objectives. Before we begin, I'd like to remind everyone that all audio will remain muted throughout the presentation. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of the toolbar, and we will respond to as many questions as time allows. Today's rounds will last approximately 1 hour, and please note that they will be recorded and made available for future access. So before we begin the Grand Rounds presentation by Dr. Lal, let's look at a case study that illustrates several key concepts in hemoglobin H disease management. Please keep this case study in mind, and we will discuss it later in the hour. Okay. So our case is of a 13-year-old Laotian female who was diagnosed with hemoglobin H constant spring at birth, essentially. She was noted to have a variant hemoglobin on newborn screen and was discovered to have 19% hemoglobin VARTs on hemoglobin electrophoresis. And her genetics was subsequently done actually with Dr. Lal's hemoglobinopathies in Oakland lab. And she was found to have the Southeast Asian gene deletion as well as hemoglobin constant spring. So she had compound heterozygosity. She has had a baseline hemoglobin of around 7.5 to 8. And her past history of transfusions include the following. Around 3 months old, she received her first blood transfusion. She was actually traveling in Laos at the time, and her hemoglobin was low during an illness, so she received a transfusion. When she came back home, she was on chronic transfusions from then up until around 18 months of age. At that time, she was found to have good growth velocities, good energy, and her chronic transfusions were stopped. Subsequently, she required one other transfusion. She was traveling again around 3 years old. She had an infection and her hemoglobin dropped low, and she received another blood transfusion out of our country. Currently, she remains premenarchal, and she does participate in dance quite often. She practices 5 days a week and participates in competitions over the weekends. She does report some symptoms of anemia. She says she feels like very tired, needs to take a nap daily. And her growth velocities have slowed over time. So you can see here on the left, her height velocity, although never significantly high, she did drop off the growth curve. And then this is her weight, which has also been kind of trending down over time. On physical exam, she's very well appearing, though she does have prominent cheekbones that her mother and sister, who are also in clinic, don't have. Her sister also has hemoglobin H constant spring. She has mild scleral icterus and a systolic ejection murmur. Her spleen is just palpable, and she has mild pallor. Some of her annual comprehensive thalassemia testing. So she does have an annual echocardiogram. She's followed by cardiology. She's had stable dilation of her left atrium and left ventricle, which cardiology chalks up to her chronic anemia. But she does have normal LV systolic function, and she did not have signs of pulmonary hypertension. Her T2 star MRI was done a few years ago due to the fact that her ferritin was above our range of 200. And you can see that she does have some iron loading with her liver iron content 3.1 milligrams per gram. However, as she was not on chronic transfusions at that time, we did not start iron chelation. Her cardiac T2 star remained normal. I mentioned she had prominent cheekbones. We did get X-ray of her facial bones, which showed a mild diffuse widening of the calvareo-diploic spaces, which was consistent with intramedullary hematopoiesis. So here are some of her recent labs. You can see her hemoglobin is kind of at her baseline between 7.5 to 8. The rest of her counts are normal, and she does have a mild hyperbilirubinemia. Her LFTs are essentially normal. And the rest of her electrolytes here. So for her management, given her poor growth velocities that have been declining, as well as her on the lower end baseline hemoglobin, and her reports of symptomatic anemia, we started her on a 6-month trial of every 4-week chronic transfusion. Now, after Dr. Lal's presentation on alpha thalassemia, we'll get into the discussion and questions about the case. Dr. Lal, welcome.
Thank you very much. Talk to you. I'm going to see if I can get control of the screen. Okay. So we, for the next half an hour or so, we'll be discussing hemoglobin H disease. And the focus, as you would see, is on treatment update. So when we think about alpha thalassemia and hemoglobin H disease, there are a number of things that one could focus on, starting with definitions, genetics, the phenotypic spectrum, classification of the disease, its natural history. I would mention these things briefly today so that we have enough time for talking about standards of care, treatment modalities, and experimental approaches. To begin with, the alpha thalassemia, as it happens in beta thalassemia, really is a continuum in terms of its clinical presentation. So we have everything ranging from mild asymptomatic anemia going through moderate, severe anemia, transfusion dependence, and hydrops fetalis. And I'll come back to that again in my talk later on. So it is also possible to view this as there being thalassemia trait, thalassemia intermedia, thalassemia major, just to put it in terms that are more understandable from the perspective of beta thalassemia that we more commonly have associated. But what we're gradually trying to think about is that all alpha thalassemia intermedia probably just needs to be called equivalent to or just grouped under hemoglobin H disease. But if one does that, then the hemoglobin H becomes a group of multiple different genotypes of a wide range of severity. And they all, many of them, or most of them, share the finding of presence of hemoglobin H on electrophoresis or red cell inclusions on vital supravital staining. And that's where the disease gets its name from. And the other general comment that's really valid for hemoglobin H is that genotype is important for the prediction of phenotype, even though there remains individual variability within the same genotype. And it's been now 20 years since the publication of a paper by Dr. Chui on hemoglobin H disease, that it's not always a benign disorder and that one needs to drill down to it in every case. So in terms of what is hemoglobin H disease, in the traditional view, one would have said that when you lose 3 out of 4 functional genes, then there is hemoglobin H disease. But if that's the view one adopts, then it does not convey the complex genetic basis of hemoglobin H disease. And we have to consider that as in beta thalassemia, there are multiple different genetic defects that can lead to hemoglobin H disease. So starting with, on the left side are deletions that we are quite familiar with as being the more common reason for hemoglobin H. These alpha plus deletions when one of the two linked alpha chains are deleted, or they're alpha 0 deletions where both the genes are deleted. Sometimes the deletion is outside in the regulatory region, as written below. But on the other side are, and the right side are listed the point mutations that are, even though they may individually be not that common except for a few of them, collectively form a large number. And they can be located either on the alpha 2, alpha 1 gene, or sometimes can be outside of the globin gene locus. And the mechanism that they affect is there are many, but in particular, I think it's worth pointing out the termination codon mutations that lead to constant spring, POXY, and many other. So these are common enough that they form a significant portion of the burden of hemoglobin H disease. So if one combines these genetic changes, then many different groups of genotypes develop, like homozygous non-deletional, that's deletional hemoglobin H, non-deletional hyperunstable variants, and the alpha thalassemia retardation and the myelodysplasia syndromes. And there are some common examples given next to them, but each of those categories has many different genotypes within that group. In the right column, I've listed what has become the standard notation of how to represent alpha thalassemia genotypes. So there are two alphas. So the normal is alpha alpha, alpha alpha, and the first alpha represents the alpha 2 gene, and the second one represents the alpha 1 gene. So the first patient, the first row is homozygous constant spring, so that both of which are alpha CS alpha, alpha CS alpha. That's how laboratory results are often reported. The pathophysiology of alpha thalassemia is different from beta thalassemia for a few reasons. Probably the biggest reason is that alpha thalassemia is the reduction of alpha chains, and alpha chains are necessary in the fetal life. So if there's a reduced production of alpha chains in fetal life, then one has to consider that alpha thalassemia begins in the fetal life. There are two transitions that happen. We are more familiar with the transition from gamma to beta postnatally, but the other transition that happens is around the 6 to 8 weeks of embryonic to fetal switch, where the zeta chains that are the alpha-like chains give way to the production of alpha chains, and that's where the alpha thalassemia pathophysiology begins. And how it leads to the anemia is due to the overproduction of abnormal hemoglobins that is in the prenatal period is represented by the excess gamma chains or hemoglobin BARTs, and the postnatal period represented by excess beta chains or hemoglobin H. So with this background, I'd just like to move on to some of the management issues that we encounter. And the general view, which we're hoping is adopted, is that recognizing the phenotypic spectrum of hemoglobin H disease is important, and that we as in every other condition, we have to match the treatment to the clinical severity of the disease. So the proposed categories are mild clinical course, moderate severity, severe disease, and then prenatal severe disease. Fortunately, the mild clinical disease is the most frequent type that we encounter in our clinical practice. And as the disease becomes more severe, it also becomes progressively less common. What I've excluded completely from today's discussion is the alpha thalassemia major or Barth hydrops fetalis, which is a different, that is not a part of hemoglobin H disease. So when we say prenatal severe disease, it's really hemoglobin H causing prenatal severe anemia. So the goals of treatment in hemoglobin H disease are a little bit different from beta thalassemia, and that they're listed on the left side as the management of anemia, management of hemolytic crisis, then iron overload, and thrombotic and ID infectious risk post-splenectomy, in the management of transfusion-dependent patients, and then last but not least is reproductive health and genetic counseling, and how to both to manage pregnancies and the fetal risk of alpha thal major for patients who themselves have hemoglobin H disease. So starting off with the hemoglobin H with mild clinical course, the ones that we are the most familiar, most common type, and this is the deletional hemoglobin H. So there's usually a combination of 2 gene deletion with a 1 gene deletion, and sometimes certain types of alpha globin point mutations, if they're homozygous with 2 normal alpha genes, also fall into this category. And in terms of diagnosis, most of these patients tend to be asymptomatic. In California and some other states where newborn screening for alpha thalassemia is in place, the diagnosis is made at birth, but otherwise it may be made much later in life, usually incidentally or at around the age of 1 year, when anemia is discovered during the course of regular child care. In terms of its effect on the patient, children have normal growth and puberty and activity. So essentially, we recommend every normal childhood activity and not to label the children as having a disease or thalassemia, but encourage normal childhood experience. In adults, there is the possibility of fatigue because there is anemia, but we have not observed in a limited number of older adult patients over the age of 50 and 60 that we followed any significant deterioration in quality of life with age. And pregnancy seems to be well tolerated as well. Hemolytic crises are not characteristic of this group, and blood transfusion is almost never necessary. There is a gradual slow development of iron overload in adults that eventually should be managed. So more often, the clinical issue, and as represented by the case today, is the hemoglobin H disease of moderate severity. Here, the baseline hemoglobin tends to be 7 to 10 grams per deciliter. There may be symptoms from the anemia, and there are hemolytic episodes can be present. So in the anemia is present in the newborn period. If one checks the cord blood, there will be microcytosis and anemia. But for some reason, the incidence of severe hyperbilirubinemia is not really increased. Transfusions may sometimes be needed in early infancy due to the low nadir, but otherwise, as we continue to follow them, a proportion of these patients will have delay in growth and puberty also, as our index case today. Skeletal facial changes, though reported, are not really typical, and extreme skeletal changes or hemolytic facial changes, as seen in beta thalassemia, are uncommon, or if they happen, they're quite mild. Splenomegaly is more usual, and there's more reticulocytosis and more jaundice than the deletional hemoglobin H patients. And adults will certainly feel a fatigue and have a decreased quality of life. And in pregnant women, they need, we recommend special care and usually transfusions. So one characteristic is the hemolytic episodes that are triggered by infections, and hemoglobin rapidly drops, sometimes to less than 5. Transfusions are needed, and sometimes the multiple episodes per year can happen in young children because they're triggered by viral infections, but they tend to decrease with age. The iron overload is much earlier in this subgroup. And the genotypes that we're familiar with, the most familiar with is the constant spring, but there are many others, and they differ by region. So for our patients who come from Southeast Asian ethnicity or Middle East or Mediterranean, will have different mutations that cause the same. Here is a presentation of a patient who had followed at our center during childhood from 4 episodes of transfusions, and the black line in the top is the hemoglobin value, and you'd see just at a dip at the age of 8 years and 10 years. And at each of those times, the bilirubin represented in green spikes up, which we interpret as increased hemolysis, but at the same time, the reticulocyte count in blue dips down, so there is a poor marrow response. So we think the hemolytic episodes are a combination of both increased hemolysis and reduced marrow response, which is why the hemoglobin can drop so quickly. And there are many different, sometimes maybe half the patients actually didn't have recognized infection, and a quarter of them will not even have a fever. And then patients who have a more severe disease. So what do we really mean by a severe clinical course? Here it's that we are required to intervene in some way because their symptoms are debilitating. So it's anemia is symptomatic. There's a marked splenomegaly, growth failure, and early transfusional iron overload. The genotypes are less common, but some of them overlap with the ones that have moderate. And this individual variation is something we don't really understand why that is the case. It's not due to the co-inheritance of beta mutations, but it does exist. Some patients with constant spring have a much more severe course than others do. And sometimes they're unstable mutations as well. So an intervention is needed either in the form of regular transfusions or splenectomy. And finally, a brief mention of the prenatal severe anemia from hemoglobin H disease. And again, this is not alpha thalassemia major or missing all 4 alpha genes. Here, at least 1 alpha gene is present. So there are 2 syndromes that are recognized, which has made provided a little clarity to this topic, especially the work coming out of Thailand that was published showed that there's hemoglobin H babies that have homozygous constant spring or POXA, and also I think it extends to the poly A site mutations. They can develop severe anemia in the mid-gestation period and develop high drops and require intrauterine transfusions, but then they recover and sometimes don't need any transfusions after birth, or may need 1 or 2, but eventually by a year or 2 of age, their baseline hemoglobin recovers to 9 to 10. The other category, which is more traditionally known, is the hemoglobin H hydrops fetalis with continued severe postnatal anemia. And these are most commonly from hyper-unstable variants. And probably worldwide, the most common variant is the Adana variant. And these babies behave very similar to the alpha thal major babies of Bart's hydrops fetalis. so they have similar problems, intrauterine, need transfusions and preterm birth, difficult neonatal period, and continued transfusion dependence. And they require a specialized intrauterine management for essentially for optimizing the outcomes. So specific interventions in hemoglobin H disease, we are discussing transfusions, splenectomy, iron chelation, curative therapies, and new therapies in development. And of these, I will not make any too much comment on iron chelation because there are no specific recommendations that are only for alpha thalassemia. Mostly we adopted the recommendations from beta thalassemia in terms of both non-transfusion dependent and transfusion dependent patients. So beginning with transfusions in hemoglobin H disease, the first thing I want to say is that largely hemoglobin H patients are non-transfusion dependent. And that's different from beta thalassemia, where a majority of patients require at least intermittent and probably most of them require regular transfusions. The second is the type of transfusions. There are several ways in transfusions are used. The first one is episodic transfusions. So these are for hemolytic crises or hemolytic events. The second is regular blood transfusions for severe hemoglobin H disease, and especially for survivors of hydrops fetalis, and also for transfusion trials, as has been the case for in the indexed patient today. The third type, again, is intrauterine transfusions when there is hydrops, and finally, women with moderate severe disease may require transfusion through pregnancy, which can then be stopped afterwards. So in the Thalassemia Western Consortium, there are 463 patients with hemoglobin H disease. And here categorized as deletional, non-deletional are either those who have constant spring, which is our most common non-deletional mutation, and all the other non-deletional mutations. And as you can see, in terms of transfusion dependence, so the blue color representing patients who have never been transfused. So that's the kind of almost the standard for very few patients may need an occasional transfusion with the deletional type, but nobody is transfusion dependent here. And in H constant spring and in the others, again, the proportion of patients who need intermittent transfusions has gone up, and there's a small percent of regularly transfused patients. The transfusion criteria for regular transfusions is really not well defined in this disorder. There's been an attempt to standardize it, and in the recent TIF alpha thalassemia guidelines that came out like 5 or 6 months ago, and it introduces or it proposes the use of functional hemoglobin in understanding our patients, the effect of our patients' anemia on their quality of life, in understanding that the total hemoglobin represents both hemoglobin A as well as the non-functional BARTs and hemoglobin H. And to understand the true degree of functional hemoglobin, one has to subtract those hemoglobins from the total hemoglobin. And then that can be different between, and generally for the milder syndromes, they have a lower proportion of hemoglobin H versus the more severe syndromes. So on the right are a brief adapted criteria from the guidelines. So all hemoglobin H hydrop survivors are by definition transfusion dependent. The other patients who may benefit from transfusion are those who have functional hemoglobins below 6 to 7, those with frequent hemolytic events, or symptomatic anemia. And the so recently there's been publication on the criteria for transfusing beta thalassemia, and I don't we don't have time to go into the differences, but the criteria are not identical. Even though we say symptomatic anemia, there are differences between beta and alpha thalassemia in who we would propose to transfuse. So in practice, when regular transfusions are given, then again, I think it's reasonable to adopt a slightly different attitude than for beta thalassemia. The first thing is that the transfusion therapy is less intensive. So pre-transfusion hemoglobins of 8 to 9 are usually adequate, and the transfusion frequency can be set at about 4 weeks. Second is that indefinite transfusions as used for beta thal major are not considered standard of care, except for a small subgroup of patients. And third is that patients should be given a trial of transfusions when the triggering indication is controlled. And if that indication is not, it's not able, it's not able to control that indication, then or that persists, then there is whether or not a splenectomy should be offered to the patients. And it is true that there are patients who will elect to stay on transfusions over splenectomy, and it's a matter of personal choice. So that brings us to the question of splenectomy, and specifically in the hemoglobin H disease. Less is known about the other non-deletional mutations. As an alternative to frequent transfusions, splenectomy should be considered. And it improves the hemoglobin level. There are data, there's a large studies that have been done in China especially. And unfortunately, the paired data, which means for an individual patient, what is the response? That data is less forthcoming, and this is on the right side is a mix of a few different publications, including our own experience with 6 patients at our center, to show that most patients experience a significant increase in the hemoglobin level. Well, not everybody, but most will experience an increase. But why is the hesitation to do splenectomy in each case? It's because there's a risk of thrombosis post-splenectomy, and that occurs both as a DVT, but also splanchnic and portal vein thrombus. And so that risk has to be managed actively and in the long term as well. So what is the role of allogeneic stem cell transplant in all of this? So if we just consider alpha thal major, which is the Bach hydrops fetalis, then it's a standard recommendation to consider allogeneic stem cell transplant to the family. It is also the same for hemoglobin H hydrops babies who have severe postnatal anemia. These are the hyper-unstable variants. But what about H constant spring? And what about the other non-deletional hemoglobin H patients who are on regular transfusions? So here, I just want to say a word of caution is warranted, as splenectomy is a viable alternative for most patients. And it's certainly simpler to try that versus some things make it a little different between beta thalassemia and alpha thalassemia, again, because patients tend to be older by the time one decides that they are transfusion dependent, and so the risk of success and complications, etc., may be a little bit different for these patients. So, and there are also now new therapies in development that may offer an alternative. So it is not a standard recommendation to consider allotransplant for H constant spring, but could be, I guess there could be some rare individual cases. So what are the therapies in development? A brief mention of gene therapy to begin with. It's the one that is probably most advanced right now in a phase 1 study in China, the lentiviral vector that encodes an alpha globin gene. So it's analogous to doing the beta gene therapy. And the concept is really sound, because even if one could get one alpha gene into the cell that has no functioning alpha genes, the cell is converted into a deletional hemoglobin H disease. And if you have 2 out of 4 restored, then it's an alpha thal trait. But even a single alpha globin gene would make a significant difference to the globin chain balance. The second approach being taken, again, is the gene editing and correction for 2 common mutations in southern China, the constant spring and the Westmead mutation. And also an approach in reactivating the zeta globin genes. This is analogous to reactivating gamma for beta thalassemia syndromes. So a lot of attention has recently gone into the pyruvate kinase activators, which are compounds, small molecules given orally that are essential, that improve the activity of pyruvate kinase enzyme, so improving the ATP levels and energy content of red cells. 2 compounds are under development, and the first one, mitapivat, has completed an open-label phase 2 trial that was published a couple of years ago, and that's shown on the right side, showing the overall response rate in the first column. In blue is the patients who had alpha thalassemia. So there were 5 out of 20 patients, and all 5 patients actually had a response defined by more than 1 gram increase from baseline. So the average was 1.2 grams per deciliter, and all of them responded and have been long-term responders since then. Now both the compounds are undergoing current clinical trials, and we're hoping maybe by the end of this year some further data would emerge on the utility of both transfusion dependent and non-transfusion dependent patients. Finally, some other luspatercept and some hepcidin therapies are also under study. So in conclusion, hemoglobin H disease is a full spectrum of severity. It's largely determined by genotype, though there's individual heterogeneity. And we don't have long-term or even data and cross-sectional data that in older adults about quality of life. Non-deletional hemoglobin H has diverse genotypes, and we may be seeing increasing diversity because of the nature of our population from where the diagnosis is being made. Important to know that alpha thalassemia begins in utero, and there are specific types that manifest and can be very challenging to both diagnose and manage. And early results support the development of pyruvate kinase activators for hemoglobin H disease. Just a quick reminder that the first consensus guidelines for alpha thalassemia were recently published by the Thalassemia International Federation, are available from their website. And I want to thank our group here, Dr. Wyszynski, and as well as the Hemoglobin Laboratory for their continued support. Thank you.
Thank you so much, Dr. Law, for a really excellent presentation. We're going to return to the case study for a few minutes to discuss how this patient could be best managed, and then we'll move on to question and answers. trying to advance the slide. Great, thank you. So for this patient who has a hemoglobin H constant spring that you mentioned kind of fell into that moderate severity, she had some of the indications to receive some transfusions, including her functional hemoglobin being below 7. When would you consider stopping a transfusion trial? Would you consider it, what would be a success for this transfusion trial?
Right, so I think that if the indication is a concern for pubertal delay or growth failure, then we take it in 2 steps. The first is if there's a 6-month trial, and if we see a growth acceleration during that time, then we continue. But some patients will not demonstrate growth acceleration despite a higher hemoglobin, and then we stop for futility. But if it is continued, then yes, I think it's worth continuing through menarche and the expected duration of growth. And then there is certainly an opportunity to try to reduce us to stop transfusions at that time. And just seeing how patients will cope with life without transfusions afterwards. There are patients who continue to have need for transfusions and would prefer to stay on transfusions. And the next question just follows that, right? It's because there is this concern of the benefit and the risk of long-term transfusions. I think it's hard for me to, especially seeing both the adult and pediatric patients, to think about starting lifetime transfusions on anybody without being totally convinced that the long-term benefits outweigh the long-term risks. So yes, I think in the short term, everything needs to be managed as needed based on symptoms.
Great, I think that's very helpful. Yeah, we plan to monitor her growth. We can see how she responds. I'll move on to questions because we have a few questions here. One of them, or multiple of the questions are related to splenectomy. Dr. Shah has asked, what percentage of thrombosis that might have been on your slide after splenectomy for specifically hemoglobin H constant spring, and related to that, is the thrombosis risk age-related?
Right. We don't know if it's age-related or not, and the larger series have not reported on splenectomy, and so that our information is a little bit incomplete. For us, the risk is not insubstantial. It's maybe in the range of 20% or a bit higher, but with a very small group, I don't think we can know for certain. But we do try to very actively manage the risk of thrombosis, which means if we could benefit from splenectomy, we would go ahead, and if they will agree to the procedure, then we will manage the perioperative period and the first month or 2 months, often with prophylactic anticoagulation, but continue on lifetime of aspirin subsequently.
And Dr. Vichinsky mentions in the chat that splenectomy appears to increase silent brain infarct risk and may have a negative impact on iron deposition in patients. That's another consideration. Another related question, someone asked if there have been considerations for partial splenectomy versus full splenectomy in our hemoglobin H patients.
Yes, not specifically for H constant spring, but I think the long-term benefit is of partial splenectomy is not certain. And certainly one would have a shorter term benefit. We have not recommended doing partial splenectomies because I think in majority of cases, and if one looks at the larger series from other countries where the disease is a lot more common, there is continued benefit from the splenectomy, though of course we're not assured of the how close the follow-ups are and whether and how many patients are lost to follow-up. And so there is definitely room for understanding the risk more completely. But again, if what we are offering as an option is a lifetime of transfusion and chelation versus managing splenectomy and post-splenectomy risks. As long as we understand that, I think we would be able to proceed judiciously.
Yeah, we haven't performed any partial splenectomies for our thalassemia patients, but we have seen in other inherited hemoglobin disorders that there's usually only a temporary benefit of the partial, and that the spleen sometimes grows back.
Yeah, there could be a benefit maybe lasting a decade, but the follow-ups longer than a decade have not been reported. Yeah, so the chances are that the spleen will get bigger.
Dr. Baczynski mentions the same thing in the chat. The spleen sometimes goes back. There was a question about other therapies such as the pyruvate kinase inhibitors, which is, I agree, a very interesting development. The question was, do you believe the best trial endpoint is the increase in hemoglobin, or is there another clinical outcome? And I was also wondering, down to what age have they studied this?
So the original development was in pyruvate kinase deficiency. In that group, initially started with the older patients, and now the new trials have been, it's been extended down in age to much younger children. For thalassemia, the one of the compounds is being studied 18 and older. The other one is being studied as 12 and older. I think for us, the major benefit would be if we can have a compound that is approved for younger children, because this is a disease that starts really at birth, and the earlier one can institute a disease-modifying therapy, the better it is. And in terms of the benefits, I think it's both the hemoglobin and it's the quality of life indicators. And I believe both are being studied in the trials now.
Great. I think they called out, whether or not non-transfusion dependent patients could really benefit from that in the future. And I think if they're looking at quality of life metrics, then that could be very helpful. There was one early question also about alternatives that you may use for patients who are Jehovah's Witness and decline blood products.
I think it's the same recommendation that would apply to all other chronic anemias that become transfusion dependent. It would not be different. The families may opt for, instead of lifetime transfusion, sometimes they opt for something that we could do for only that would use limited number of transfusions, but make a patient transfusion dependent afterwards. So depending upon an individual family perception, so that would be a discussion to be had. But in general, the recommendations don't differ between different types of transfusion-dependent anemias, whether thalassemia or otherwise.
It seems that the newer trials that are out with the pyruvate kinase inhibitors may be helpful in just boosting that hemoglobin to try to avoid transfusion.
Right, definitely. And same thing goes for splenectomy and in any other modality that might come up in the future.
Great. And then there's one last question here. I know we're a little bit over time. Judith Frank asks if you could explain the functional versus total hemoglobin measurement.
Right. So one of the differences between beta and alpha thalassemia is the excess alpha chains in beta thalassemia are not found in peripheral blood, so they precipitate. So the hemoglobin that we measure is all of that hemoglobin works to carry oxygen. In alpha thalassemia, the beta chains and the gamma chains in fetal life, they are still, the tetramers are soluble and they get measured as part of the total hemoglobin measured in the lab. But these hemoglobin species do not carry oxygen, so they're of no use. So the functional part of the hemoglobin is the hemoglobin A value only. So if one could do an electrophoresis or measure the percent of Bart's and H, and then subtract that from the total hemoglobin, then that's the functional hemoglobin. It's not routinely available, but it's very important, especially for the management of alpha thalassemia major or the Bart's hydroxyfetalis babies, because that's a constant question of how to adjust their transfusions. For hemoglobin H, I think it's more important from the conceptual reason, and so that if somebody is running a hemoglobin of 7.5, but has 10-20%, they may have 20% hemoglobin H, for example. So the true hemoglobins are a lot lower. And then we would really worry about the effect of chronic anemia over lifetime, both in terms of cerebral vasculature, as well as just the general organ function over a long period of time. These are data that are not actually available because the follow-up in adults with alpha thalassemia is remarkably, there's very few studies for adults.
Great, yes, thanks for going through that. And I think that's really a helpful reminder we look at the hemoglobin value that's printed out on the lab sheet, but that's not what that patient may be feeling that is traveling around their body carrying oxygen. And also thank you for bringing up the new guidelines that are in the Thalassemia International Federation. I think that'll be really helpful. I think that we have answered the questions. I want to thank everyone for joining us today. If you have any additional questions about today's presentation, you can see on the slide Craig Butler's email or the CDC email. You can feel free to reach out. And the presentation will also be archived and available on the CDC's website soon, as shown on the slide. Thank you again for joining us and having patience with our issues with IT, and have a great afternoon.
Thank you. Thank you, everybody, for joining.
Thanks, Ash.